We're live on YouTube and we're live here as well. Awesome. Guys, I'm going to kick things off with the topic of today's chat and then go straight into some Q&A for you guys. So if you've got any questions, you can drop them in the comments whenever. And if you're watching this after the fact on YouTube, then you guys can always post down there as well, because we do read and reply to all the comments. So the topic of today is what are the best stretches or the best way to stretch if you have back pain and sciatica. And I'm going to start this one out by just helping you understand how not to stretch if you have these injuries. And fundamentally, back pain and sciatica isn't the injury itself. The injury is something that is causing the back pain and sciatica, which will invariably be some kind of injury down here in the lower lumbar spine. And all too often, we think of stretches to ease the pain, the back pain that we're experiencing, the sciatica we're experiencing, being things like a child's pose, or being something like a knee hug, or something like that that involves bending and rounding the lumbar spine, flexing the lumbar spine, straining all of these ligaments on the back here, disregarding the underlying disc herniation that might well be there down in the lumbar spine. And so we end up doing stretches that do not help the underlying injury. That is the thing that we are prioritizing. We are prioritizing a structure, a joint in the lumbar spine, most commonly L5S1 and L45 being the two most common sections of the lumbar spine. And I will come on to walking in a little bit. And those are the structures that are injured. They're injured squashing down, and they're usually injured squashing down, leaning forwards in some way, shape, or form. And so stretches that are just going to be stretching those out even more in that kind of manner, flexion, forward bending, is a problem. And I won't get into the details unless you guys have any questions on it as to why they're recommended all the time, because I've covered that in recent live sessions. But what should we do instead? And what we should do instead is spinal decompression type stretches. And these can come in a number of different categories, and I'm going to cover the basic ones that every single one of you guys can do. They are staples. They are arguably the best stretches for lower back pain that anyone can do with zero cost at home, and then kind of build on that to other versions you could do, as well as options in the clinical environment as well. And I'll touch on those briefly, and if you guys want any more details, you can always ask questions or comment down below. And the first one of these is the towel decompression. This is where we take an ordinary bath towel like so, we roll it up to about the size of a foam roller, right? You're not using a foam roller because foam rollers roll, they don't compress down a little bit. And this will compress down a little bit, meaning you're not worrying about rolling, you're just relaxing over it. And there are videos, and I'll show you guys briefly in a second behind me how to do this. But why are we doing this? The reason we're doing this is most of you guys spend a significant amount of time every day sitting, squashing down like so. You'll notice that I'm eliminating the lordosis. You should have a natural lordosis. And so you feel tension in this area and tension in this area. By this area, I mean the ligaments that run in between the spine. And by this area, I mean the muscles of the lower back. Often we feel tension in those areas. And so we need a stretch to alleviate the tension in the entirety, right? Take pressure off the disc, but also take tension off these ligaments. And that's where the towel works. It creates an upward force in this direction here to support the natural, lordosis. And in the process of supporting that lordosis, we get a little bit of decompression through the lumbar discs in a uniform manner, as opposed to like that, which is a problem, forward bending. What we also get is a taking off of tension of the ligaments on the back here. These guys, make no mistake, are trying to knit back up properly again. By you pulling them like that all day, they are tense, tight, and tired, and they need a bit of tension taken off them. And so this is what the towel does. And just to demonstrate and show you guys how to do it, you literally carefully get down onto the floor. I'm not going to be as careful as you should be if you're struggling with lower back pain. You'd roll it more tightly than this, lift your bum up, and then relax down over. You place your hands on like so, and you just chill out here. And we've got a specific instruction on how to get off this position, etc. There's a dedicated podcast on this particular stretch. We carefully roll to the side. Obviously, there's a squat rack in the way for me, so try not to do it right next to your squat rack. And then you pop yourself up slowly, and you might take a few moments before you get up, and you would do this for a couple of minutes, 2, 3, 4, 5 minutes at a time. I wouldn't do it longer. You do it more frequently as an antidote to the stress and strain squashing down on that spine every single day, so that you can have a stretch that is alleviating tension, but it is not violating some of the principles of a neutral spine. It's supporting, taking pressure off the lumbar spine in a safe and sensible way, whilst also taking tension off these ligaments here. So that's the first and most essential stretch. That's what we call the towel decompression stretch. And one of the reasons it's so helpful is because you are sitting down every day. Most of you guys watching this right now, you're sat down, flattening the lumbar curve. it's a problem. Leo's asked, regarding the towel decompression, could it be used while lying on our belly and not on our back? Not really. If you're lying on your tummy, so that brings me nicely, Leo, thanks for the prompt there, onto the second stretch that you guys can do at home, which is the bed decompression. Why is this particularly good? Well, it kind of goes into Leo's question here, and that is that when we lie down on our tummy, we tend to drop into a bit of a lordosis. Typically speaking, the lordosis is more likely to be preserved rather than eliminated unless we've got a towel underneath our tummy, which would be a mistake, or a pillow. And so we lie off the edge of the bed and we can use our arms to press into the side of the bed. We've got demonstrations on this on the website and in the membership program, so don't worry about this. You can look afterwards. I can't demonstrate because I haven't got a bed behind me. But you're using your arms to press in to create this pull. And in fact, I might be able to kind of demonstrate. It's not going to be quite as good as it needs to be because this isn't high enough. But essentially, you're off the edge of your bed like so, and you're using your arms here to press down, and that is the direction that you go. But because you're on the bed, you kind of anchored to it, so you just create a little bit of decompression. You can see me moving a little bit, creating this elongation of the lumbar spine. You can combine this with breathing to slightly intensify the pull. There are full instructions again. But both of those are great stretches. But you have to understand that stretches of the lumbar spine, pumping, decompression of the lumbar spine, as great as it is for these herniated discs and bulging discs in the lumbar spine, it is not building strength. So it is a useful relief-based tool, as all stretches are. But please do not fall into the trap that so many fall into in thinking it is getting your back better again. It is not. It is part of the process, but it's not building anything. It's just helping offset the stress and strain of daily life. Then we move into the next kind of option, and that is going to be the inversion table type tools. And these are great if you use them in a sensible manner. We've got a tutorial video on how to use this. Rather than going completely hanging upside down, actually going from horizontal to slightly inverted, holding it there for a moment and then coming back up, maybe 15, 20 seconds like this, and then coming back up to create this pumping pull. And the reason we say that is because that, just like the bed decompression, this pumping effect is a nice thing to do, and it tries to emulate what we do in the room behind the wall here, the colored wall or the glowy wall, which is spinal decompression. That is the clinical application of this, where we get strapped in on a big table and then we get pulled and we get a pump created in the lumbar spine. It's much more clinical. Obviously, that's going out your way, and I've tried to order those in order of cost, expense, effort, energy to actually do. And so, you know, you can get a good teeter table for around about £400, $500, $600. I would be very cautious about buying a cheap inversion table because you're hanging upside down from the ankles and you do not want it to fail lest you have other problems. And then you've got obviously the clinical application as well. These are great stretches that actually help take strain off the underlying injury. And while we've got sensible, strategic stretches like the hamstring stretch done correctly with a neutral spine, those always have second order consequences, second order benefits by making the hips a bit more mobile to lessen the strain on the lumbar spine, for example. So hopefully that makes a bit of sense with regards to those stretches. I'm jumping into some questions now from the comments. And one of the ones that I saw very early on, I'll kind of scroll back through some of these guys in a second, was just as it pertains to walking. And understand walking is very, very similar. Walking within aggravation-free distances that do not exceed 20 minutes, because I think 20 minutes, if you're doing longer than that, what are you doing? Like, are you taking away from some other rehab you could be doing that's more productive? Understand that walking plays a relief-based role and is not cumulative in its benefit. So if you're walking for extended durations and it's not bothering, that's great, but you could be spending that time doing actual strengthening work instead, rehabilitation work. B3GR8 has, I don't like the theme online, unfortunately, that so many take of commenting or criticizing or lambasting other people's programs and this, that, the other. So I don't particularly like commenting on other people. I think the approach, specific aspects of other approaches, I can definitely talk about those. The utility of the back extension machine, I think, is way overplayed. I think it's unnecessary. I think it's a duplication of a hip hinge, and that's pretty much it. But at the end of the day, guys, remember, like, by and large, whoever you're talking about, whoever you're following, like, they're trying to help you, right? And that's, I think, the most important thing. I think you get an idea of the sincerity, I suppose. And whether I agree or disagree with the different things that people are doing, I don't think it's the kind of thing where I can just have a quick comment, because that's not even a fair appraisal of the other person's material. So I don't like getting dragged into that kind of thing, because I think it's very unproductive, and we want to try and make a positive space here. You know, that's very important for me personally. So Frankie said here, hello, herniated disc, L45 since 4 weeks. I can't walk, sit. If we've got a herniated disc, we've got an injury right? Bulging, herniated, to the lumbar spine. And people will have a degree of pain from the actual injury itself, just like if you broke your leg is going to hurt. But often people will also have this residual degree of discomfort, pain, soreness, that's associated with the inflammation that builds up in these small holes, because the lumbar spine is very different to other areas of the body in that these small holes are not stretchy. So while you can accommodate a lot of inflammation building up around your swollen wrist because there's lots of stretchy skin and capsular tissue there, you cannot accommodate that in the same way in the lumbar spine. So people find, like, I can't even get comfortable because there's a lot of inflammation, and that's where inflammation management is really important. So having tools and strategies to take pressure off that disc, but also manage the inflammation, trying your best to do little bits of walking within aggravation-free limits. If that's only along the kitchen countertop, leaning on the side like so, then that's maybe all you can do to start with. Contrast bathing is a particularly helpful one. And then frankly, immediately starting the principles that we talk about in the program with the core phase 1, 2, 3, and 4 of the program, starting immediately learning the simplistic exercise to start to control your lumbar spine. Much of the flare-ups, the aggravations, the moment-to-moment irritations that you're getting of your sciatica, of that herniated disc, are because you allowed the spine to move and put strain preferentially through that L4-5 disc fibers, or those L4-5 disc fibers that are strained, vulnerable, and weak. You need to learn how to brace and protect this section here, learning how to control the midsection, control the core, learning how to control the core whilst doing actions of daily living, so that you're not like kind of doing that kind of stuff and wobbling all over the place and bending and twisting. You'll see things online about people talking about, bend and twist, the back's supposed to move. It's injured. And right now you have no ability to control. I have no ability to control. Everybody reading this has no ability to control L4-5. But what you can do is control the trunk section. And if you can provide trunk stability through engaging the core and integrate that with movement of the hips to allow you to live and get around in the real world, you'll find that the day-to-day activities get safer and safer and safer. And as a result of that, the flare-ups start to calm down in conjunction with other relief-based practices such as contrast bathing, the towel decompression that I just mentioned, the bed decompression, and others done carefully and correctly, and realizing that learning how to do these things invariably involves doing them incorrectly to some degree, and then refining that process. If we could already do it, we wouldn't be in this trouble, and then building from there. So hopefully that's helpful, Frankie. I would definitely, any of you guys that are struggling like this, especially like the sooner it is the better, right? The sooner it is the better. But the best time to plant a tree was 20 years ago. The second best time is today. So any of you guys that need any more help and structure and support, go and check out the link in the profile page, or if you're on YouTube, go and check out the link down in the comment section and check out the program, because that will give you the structure that you need to actually start to go better. And more importantly, the education as well, to start to understand these things. Because when you understand these things, it feels like a less hopeful, like a less hopeless, never-ending trail of suffering, which for some people, that's been going on for too long. McGill Big 3, I don't necessarily agree with some of those things. I think often how the McGill Big 3 is taught, you're often taught to flatten the lumbar spine. With regards to specifically the roll down, where you put your hand behind your back, the instructional, if you listen to McGill talk about it, the instruction is that this is supporting the lordosis. Have you seen my forearm? Does that look like the same as that? That was going to create a tilt. It's not going to support the lordosis. This is, I struggle with this one. Why someone who's He's really good. Like a lot of his stuff, we really do, like there's a lot of alignment there with what we talk about and what McGill does. But like that is not straight. So you're just going to engineer plus if you've got the shoulder mobility to do that. And if you're not doing that, you're probably going to be flattening your lumbar spine to the ground. And I've seen many people who are teaching how to do the McGill Big 3 are teaching it incorrectly and in contradiction, because he specifically states, if you watch him talk about it specifically, putting that there to support the lordosis. Others will say, flatten the back into the ground, impress your spine. That is incorrect. They haven't learned it correctly. They don't understand, unfortunately. And so this is one of the great tools. Like for example, we talk about the dead bug as a mechanism for learning to, in a safe environment, off weight bearing, to engage the core and create an ability to control the core in the safest possible environment, right? You're lying down. Nothing materially bad is going to happen to you in this scenario. In terms of the forces at play are significantly less than you, quite frankly, getting dressed in the morning. So as much as you might aggravate yourself, it's very safe. Having a smaller rolled up towel, just to fill the void underneath your lower back. So for example, if I lie down here on the floor, right, you guys might or might not be able to see, wrong color shirt selection today. There's a little bit of a gap, right? Obviously the full size towel that we discussed earlier to stretch the back is inappropriate, but a little bit of filling of that gap with a smaller towel gives me an awareness. One of the big problems that you guys have when you have an injury is some of you guys haven't trained in the past, And of those of you that have, you now have a lack of awareness and proprioception in the lower back specifically. So having that towel underneath the lower back gives you something to feel that is less sophisticated than feeling the inner workings of your spine. And so you can feel that your back is resting on the towel. And then when you do, for example, aspects of the dead bug, you can feel that your back lifts off the towel, and you know that that's incorrect. Equally, you can feel that the back is pressing into the towel, and you know also that that is incorrect. You are flattening the lumbar spine. You're not actually doing the exercise correctly, and therefore it helps you refine the movement. But yeah, I don't think the McGill Big 3 implies that those are the 3 exercises you can do to recover from back pain, and they're missing things in a significant manner. And so like our attempt to kind of come up with like the core 5 was an attempt to kind of take that and try and make it even more all-encompassing. Something that's accessible to absolutely everybody. A lot of people don't have the strength in the upper body to do a side plank. So how do we work around that? A lot of people don't have the ability to do some of these things. So we wanted to make, for example, the core 5, the exercises that we leverage in the program, the dead bug, the marching bridge, squat, hip hinge, and step up, the single leg hip hinge. Any human being can do those, and they can scale to the infinitesimally easy. If you're going to do, for example, a single leg hip hinge, you can literally stand and hug the wall, right? I'm being a bit hyperbolic. You can hold on to the wall. That might be where you start. That looks like nothing, but some people will start there. Others will start being able to go a bit further with a single leg hip hinge. Others will find the single leg hip hinge actually easier than a double leg hip hinge. Some people with a step up, right? You start with a very, very small step, holding onto something. These are exercises that teach you, when done correctly with appropriate focus and intention, they teach you how to do simplistic movements that are emblematic of real life. How often do you lie on your side and just do that? Now I know we used to include side planks because they are not bad, but they're not the best. And so hopefully that makes a bit of sense. Leo has said on UGP, you stated that that pain in the knees, hamstrings, upper back, neck, etc. can be due to inflammatory injury in the lumbar zone. Not neck, not upper back. But symbiotically, the weaknesses in those areas also cause pain. Not quite. And so it would be right to move to strengthen those areas as well. So let me clarify some of that there, Leo. So I was commenting in real time. So fundamentally, if we have an injury to the lumbar spine, right down here in the lower back, okay, L5S1, that can refer pain most commonly to the buttocks region, the back of the thighs, and down into the lower leg. That's where we can experience pain. We can also notice that we have weakness in the upper back. And one thing, for example, which is I think where some of these comments might have come from, and hopefully this helps you understand what I'm saying better, Leo, because I know you've jumped in on a couple of live streams. The actions of learning to start to hold yourself better again employs the muscles in these regions of the back, right up here. And it's very common that people are very weak in those areas. And so it's not unreasonable to notice that there is soreness and stiffness there. Weakness in the upper back does not cause an injury. And this is where it can increase the factors. It can be a contributing factor that led to you being in a position where you injured yourself. But it is the injury itself, the instance in itself that led to the injury, I would state. I would also say things like weak knees, weak hips. And they're not really weak knees and hips, they're weak legs and weak buttocks muscles are very, very common, and they're very commonly associated with lumbar spine. And if you've got weakness in those muscular groups, which is basically a large percentage of the population, then you probably have dysfunctional movement patterns and probably have a lack of resilience in the knees, the hips, the ankles. So it's not unreasonable to suggest that an individual can have multiple vulnerabilities, and then when one card falls, many follow, or many become overstrained because they simply aren't capable of of being lent on to support the lumbar spine. So for example, when I couldn't put any load through my left knee, when I'd done the meniscus a couple of months back, I had my other strong leg and I had a strong core and I had a back, and make no mistake, because I couldn't move correctly, because I literally, as soon as I got to a certain range, I could do stuff here and I could do stuff down here, but as soon as I got to like this range, this was like a kill switch, gone, no power. And so what I found myself doing is, thankfully, I had a strong back and a strong other leg and strong other muscles, so I could compensate because I was having to use my back more, which is not ideal for the long term, but it was necessary whilst my left knee was not able to be utilized in its appropriate manner. And so if I had weakness in other areas, what would have happened is I would have strained my left knee, meniscus, and then because I had to use my back in funny ways, I've now herniated a disc, and then my right hip goes as well because it's weight bearing more. And that's what happens to so many people, because they do not develop strength, whole body, which is why you're doing whole body exercises. And fundamentally, all of those areas that Leo has mentioned, maybe with a slight exception of the neck, are are strengthened when you do the exercises that we talk about. If you're doing an appropriate hip hinge, you better believe your upper back is working. If you're doing an appropriate squat, you better believe your upper back, your mid back, your core, etc. is working. I would argue that the squat and the hip hinge, when done to their final form, let's say, they are the best core exercises, because there's no way you can exert the same amount of challenge on the core with anything else in terms of pure loading, pure challenge, pure strain. If you're halfway through a squat in this position here, or rather a hip hinge, sorry, in this position here, if you do not have strong core, you're just going to buckle over, right? So people don't realize that actually, the dead bug is a good exercise to learn the core, but actually to really build true strength in the core, you're going to be doing your squats and hip hinges. And of course, the asymmetrical variations, such as the single leg hip hinge, such as the step up, Bulgarian split squats, and other such asymmetrical activities can further the development of extra balance components to that core and left to right kind of attributes, let's say. So hopefully that makes sense, Leo. And guys, if there's anything I say, like I'm doing these lives and there's a back and forth, there's a comment section for a reason. So I appreciate the questions because it helps me explain things to you guys more. And if one person hasn't understood it or one person has some questions, then probably some other people have some questions too. Do you think the bird dog is a good exercise? Louise, we've got a video on the bird dog. It's fundamentally the same as the dead bug. So the bird dog is when we're on all fours and we're doing, that. I think the bird dog is less good. And I will explain why. A lot of people struggle with the proprioception, the awareness of what their back is actually doing. And for a beginner, it's very helpful to have your hands on your waist so you can feel your core whilst you're doing the exercise. Or like I mentioned a little bit earlier, if we're trying to control the lordosis, having a towel underneath our lower back. We can do none of those things while we're doing the bird dog. So the bird dog is not, it doesn't have the same ability to provide external additional supports in the understanding of what our body is doing, our hands. So for example, right, if I'm in the bird dog position over here, like so, I can't put my hands anywhere or get any other feeling other than what I feel, if you get what I'm saying. Whereas when I'm doing the dead bug, I can have my hands on here and feel, oh, I lost it. Okay, yeah, I got it again. Oh, I lost it. I can have the towel underneath my back and feel that my back came off the ground. And so it's a duplication of the dead bug, but it's got those inferior qualities to it that mean that it's just not as good. And why do the same things, right? So that's where I'd say swap out your bird dog, do a dead bug instead. And I think it's regressible, meaning you could do easier and easier versions of it in a much more common sense way, or instinctive or intuitive way. Leo has said, thanks a lot. Thoughts on training anti-function? I'm not sure what we mean by that. And in terms of the anti-extension, anti-rotation, anti-lateral flexion, I'm going to make a stab at it. And what I mean by, what I suspect we're doing there is an anti-flexion movement might be just, I think we're overcomplicating the statement stability. Because when you are, for example, doing a step up and you've got a load on one side, you are stabilizing for lateral flexion and maybe a little bit of forward bending. So you're providing that anti-force, whatever it is. I think one of the big things, I was at a strength conference with a guy, really good guy that I saw on Instagram this weekend in London, Sean McInroy, bold guy with a big moustache, and he's Australian. Really cool guy, very, very friendly. But I think one of the big things, one of the big things I kind of took away from that, and I've known for a while, but it was kind of nice bit of confirmation, is that we need to understand things at a high level so we can communicate that actually it's an awful lot more simple. And I think there's too many people perhaps making things out to be super, super complicated when actually, using all of those different terms, when if we just said stability. Don't let your body move in any direction other than staying still. And that's stability. I think when we start to get into these other terms, I think it just ends up confusing people and losing people and making it feel like that you're so difficult that you couldn't possibly do it on your own because you're not smart enough. And actually, that's not true. It's not true at all. Like, you can do an awful lot, and if we just simplify the message, then it's accessible to everybody. And there are plenty of professions where they use significant amounts of technical jargon to quite frankly bamboozle and confuse the ordinary person to make it think like they're saying things that are a lot smarter than they actually are when you break them down. Alice has said, can nerve damage from nerve compression be permanent if not treated. It really depends on the circumstances, Alice, and whether it is actually permanent. So if you have a nerve compression that is giving you constant 24 hours a day symptoms, and we have this sort of nerve compression that is creating the damage, then you will notice a significant number of, notice pain, you'll invariably notice some degree of motor loss, so that's muscle loss, muscle power loss, and it will be always there. And that might be a circumstance which they get you in to have a little bit more of a discussion about what they're going to do about that, and that might be one of the circumstances. They might consider things like, the presence of foot drop, for example, as a consequence of that, right? But I think a lot of people, the term nerve compression isn't necessarily synonymous with nerve damage. They're not the same thing. And maybe saying nerve irritation would be a better statement and much less daunting a prospect. And so if there's actually nerve damage, so if we use an example of a nerve damage that we see, not loads, but often, we see that the person has a microdiscectomy, a lumbar microdiscectomy. They cut a bit of disc out, but they bump a nerve and create a bit of bruising, let's say, in one of the nerves during the process. And the person notices they've just got this constant numbness or tingling on their big toe after the surgery. If that's a peripheral nerve, Alice has said, numb foot since I've had it, plus lumbar pain, and muscle mass is bad, plus foot drop. Okay, so this might be that category. If the cause of the nerve damage has been removed, so the disc is no longer pressing on the nerve, but we still have those residual symptoms, like what I was just mentioning, then what you'll often find is that the nerves in the peripheral system heal very, very slowly. And so if we thought discs healed slow, these nerves heal even slower. And what you'll often notice if you do the right sort of rehabilitation work, if it's in the peripheral nervous system, which let's hope it is, then it will heal slowly. So take the numbness or the altered sensation that you've got in that foot and put that as a separate symptom alongside the pain and this, that, the other, and work on doing the rehab for the back, and notice that stuff will probably that stuff will settle fast, and this will probably remain for a longer period of time. But if it's going to heal, it will heal, but it'll heal very, very slowly. I hope that makes sense, and I would suggest that it's really it's not very common, but in terms of the post-surgical scenarios where the nerve gets bumped or irritated, not irritated, bumped or bruised a little bit, it is something that people often notice they have in a residual manner. And slowly, if it's in the peripheral nervous system, it will go through a healing process. So that's kind of the best thing. But try and park that sensation for the time being and don't worry about it in that regard, but observe it and focus doggedly on the rehabilitation over the months ahead, and every so often just go back and say, am I noticing it as much? And what will often happen is you start to notice it less frequently, apart from when you're lying in bed and there's no other stimulation. You can distract yourself from it more, and that's a good sign as a general rule. But when you're lying in bed, maybe you can't sleep or something like that, and you think about it and you're like, oh yeah, that toe's still a bit numb. I can't quite feel it. That's generally the way those sorts of things go if it's going to heal. Martin said, hey, disc herniation L5S1, started doing a hip hinge, squats, dead bugs and planks. I wouldn't be doing planks personally, don't like them. But stuck now since I don't have any more progression and feeling less pain and ingestion. I try things like decompression, but it doesn't feel good. You haven't finished. There is infinite progression on the squat and hip hinge, Martin. I understand once you've learned how to do these exercises, we talk about the core 5, right? The squat, the hip hinge. See the weight bar behind me? Maybe don't go to that, you go to the dumbbells first, and you progress with the load. You build with the load. That's what you need to do, Martin. So you've done a good bit of work to get maybe proficient at those exercises, but you have to actually build strength and tolerance, right? So you've got two parameters here. You've got the strain. We're just going to use strain because I took it from Whoop on here, right? It's just some kind of arbitrary measurement evaluation of the sorts of strain we put our back under on a daily basis, the injured area, the herniated disc. And our daily life might put this much strain. A lot of you guys, when you're struggling, your daily life puts this much strain, and your conditioning, control, etc., capacity is here. And so the purpose of your rehabilitation is so that your rehab, which turns into strength training, is up here, builds your capacity. So your capacity is up here and daily life is down here. Now you've got so much scope to effortlessly breeze through daily life. I use the example of a trailer. If you've got a 1-ton trailer and you stick a little moped on the front, the moped is going to scream at you trying to pull, or a scooter. The moped is going to scream at you trying to pull that trailer because it just can't. It's too weak. When you make the moped stronger, Range Rover, Dodge Ram, something like that, depending on where you are, Cybertruck, it pulls off effortlessly, no noise. And that's what you're doing. But if you're just learning technique and you're good at that, that's great, Martin, that's the foundation, right? You have to get technique first to then earn the right to safely start to apply increasing amounts of load to actually find the right level to challenge yourself so that you can make change over a period of months. Muscle change is going to happen over a period of weeks and then successfully over the months. As the months go by, you're going to build strength and resilience. So we probably just missed that we have to continue to do the work over time. But great, we've got to get technique right first. God Sendo has said, I have L4-5 stenosis. My doctor is pushing me to have an operation, so I'm scared to death. Is it compulsory to do surgery? No, it's not compulsory. I don't obviously have all of the scenarios, but we want to understand what stenosis is not a diagnosis. Stenosis is a part of a diagnosis. It's like if you were like identifying a criminal. You say they had pink hair, blue hair, black hair, whatever it is, right? That's only one part of the description. The rest of it is that they had blue eyes, they had, a coat on, the coat was pink, or whatever it may be, right? I'm just thinking of random colors here. Okay? The stenosis is one thing, one factor, okay? We've got the disc bulge here. That is what invariably is causing stenosis. It's very windy outside. Stenosis just means a narrowing of the hole. So invariably there's some sort of disc component. There might well be some facet joint hypertrophy, meaning this enlarges. Like a degenerate joint, like an arthritic knee is enlarged a little bit over time if it's very arthritic. It could be some ligamentum flavum hypertrophy. There's a ligament in here which sometimes, if under strain for an extended period of time, will start to enlarge to try and deal with the stress and strain. And that can also be the cause. So we've got to understand what the cause is. And what are they actually doing? Are they just doing a straight up discectomy? Okay, that's microdiscectomy is going to be a low tier operation. Are they talking about something else? I have no idea. But you need to make sure that you have an idea. And if you're just on the proviso that it's L4-5 stenosis, then your doctor hasn't done a good job of actually explaining what's going on. And that's really important to understand. What have we got? Louise has said, is it normal to feel pulling tight at the bottom of the spine when hip hinging? Let me just get rid of that. Yes. So let me explain a couple of things that you might feel. And you want to, there's a great test to help make sure that you've got technique right, because you must make sure that you're doing the technique correctly, because there are scenarios where you can get this and you're not doing it correctly. So if we're thinking about the bottom of the spine, we're thinking about here, L5-S1, lower lumbar spine. You might be feeling things a little bit lower down as well. That's fair enough. Assuming we're doing it correctly, one of the tests you can do is to get a little bit of tape, just ordinary packing tape, and you can stick it along this part of your lower back and then do the hip hinge. If the tape is stretching or pulling off your back, then you're probably doing it wrong and you're not actually stabilizing the spine. However, let's assume we're doing it correctly. What should you feel? Well, you should feel tension in two areas on the hip hinge. Area number one is that as you do the hip hinge, your hamstrings hit tension when they can go no longer. Now, they're going to want to pull, and if they hamstrings, they are working against your lumbar erector spinae muscle, so the muscles in the lower back. People sometimes say, my back feels tense. I feel tension in my back. My back feels stiff after doing hip hinges. Yes, I hope so. Like if you just did a bunch of bicep curls, your bicep would feel tense. It'd be engorged with blood. You might not be able to touch your shoulder because it's stiff, because you've just worked it out. Make no mistake, your back muscles are working on the hip hinge. So when you get to the bottom of the range of rep, there is a tension, an equal and opposite tension between your hamstrings and your lumbar spine muscles. If you do not have the tension in your lower back, it buckles, and you do that. And that is quite clearly not a good thing to have happen. We do not want that taking place. And so it's very, very normal to experience that tension when we are doing it correctly, thoughtfully, carefully. If we didn't have it there, it would be a problem because we'd be doing the exercise incorrectly. We wouldn't be bracing the area appropriately. So it sounds like you're probably feeling the right sort of thing. However, it could be that you're not quite doing it well enough. And maybe as you get to the bottom there, you're pushing yourself a little bit too far and you're getting a bit of that happening. And that's pulling on the scar tissue post-MD. I'm assuming we mean microdiscectomy. It's pulling on the lumbar spine because we haven't quite held it in place correctly. And so there might be a specific point. Maybe back off that point, that range of motion. Understand precisely when we're feeling it. And then using things like a chair, for example, to standardize the depth. So maybe you stand close to your chair and you only go to here. Because if you go to here, you feel it. So you only go to here. And now for the next couple of sessions, you're only going to go to here, and then you might retest here. Oh, I've made progress. I don't feel it anymore. Great, awesome, right? You've just got to create these constraints to make sure that you're really engineering really good form. Storyteller has said how to sit for longer with a disc herniation and sciatica. I can't bend the spine, that's good, and I want to sit. But if I want to sit straight for university classes, you can't. That's like saying, how do I run on a broken leg? Right? That's the wrong question. I'm afraid. I'm sorry. I am sorry. It's the wrong question. What you will notice, there's no quick fix, right? You can do things to play around with it, but you have a disc herniation, probably L4-5, more likely L5-S1. Sitting puts more strain on that disc. How do you improve your tolerance? You build strength and tolerance in that back. You rehabilitate that back. So what you will notice is that as you go through the recovery and strengthening process, your back will be able to bear more load. As it can bear more load, things that increase the loading on the lumbar spine will become easier and less provocative. Vis-a-vis, you build your squats up, your hip hinges up, so you're doing 30, 40, 50 kilos or so on, and probably much before then, to be completely honest. And you'll notice that you can sit for longer before pain kicks in. You can walk for longer before pain kicks in. You can drive for longer before pain kicks in. Your rehab gets you guys the outcomes that you want. We talk about, I want to sit longer, I want to play with my kids without pain, I want to do this, that, the other. Your rehab gets you there, but you have to progress through the rehab. The doctor said it is decompressing the nerves. Yeah, because what they're doing a bad job, I think, Godsend, of complaining these things to you, I'm afraid, of explaining these things to you, I'm afraid. When this space is smaller, say we've got a disc herniation in there, and we have stenosis, the reason that is a problem is because it irritates the nerves, it compresses the nerves, it creates increased pressure in this region, especially with presence of inflammation. That's where most of your symptoms come from, right? And so, yes, when they decompress the area, if they remove that bit of disc, so for example, Godsender, was it Lucy or Louise said a second ago about, yeah, Louise said she's had a previous microdiscectomy. That would be to deal with the stenosis that is caused by the disc being in the wrong place, and the disc, and maybe directly or otherwise, was irritating those nerves. And so it's decompressing the space so the nerves have more room, but that again doesn't tell you what is actually being operated on. Are they cutting a bit of disc away? Are they doing a laminectomy? What are they doing specifically? And what is the underlying problem? Again, we're just talking about symptoms here. I've got stenosis, I've got compression on the nerves. Those don't tell us what the problem is. Those tell us what the consequences of the problem are. I've got sciatica, not the problem. This problem is I've got an L5-S1 disc bulge on the left-hand side that is hitting the root of my sciatic nerve, or one of the roots of my sciatic nerve. The L4-5 is the disc. This problem is the problem. There's a result of stenosis, a result of nerve compression. There is a result of X, Y, and Z. But I need to know what the problem is. I mean, you know what the problem is, right? You've got a segmental injury to that section of the lumbar spine. Most likely there's some element of disc involvement. Does it really matter from your point of view? No. But you want to know what's going on if they're going to operate on you, and they need to have a clear understanding. Otherwise, well, if they can't communicate it effectively to you, I'd just go and speak to someone else and get a second opinion. And I don't think surgery is anything we particularly rush into unless we've got the presence of emergency symptoms, and generally we're not on YouTube talking about it in that sort of scenario. We've already had it. So hopefully that gives you a bit of, at least, points to go through. Godsend. What have we got here? I've got tight back muscles, and the doc said dystonia, but I refuse to believe. Yeah, I think tight back muscles is often how these sorts of back injuries start. You get given a bunch of muscle relaxants and stuff like that, told to go away, and then 6 months to 18 months later you have an MRI and, oh, I've got an L5-S1 disc bulge. I could have been told that 6 to 18 months ago. In those sorts of scenarios, I treat it as a disc bulge and do the rehab work, and you'll probably notice you get better. Irina has said, I have surgery at L4-5, right side, after I have some issues on the left leg. Why? There are a number of different reasons for that. I don't know exactly what surgery we've had, but one of the annoying and confusing things about lumbar spine issues is that the symptoms that you can experience can swap sides left and right. You've got nerves like what's called the recurrent meningeal nerve, which is a nerve that comes out on this side and crosses over to the other side, so it will innervate the disc fibers on this side, as well as some on the back in the middle, as well as some on this side. It's also sometimes called the wandering nerve, and so much that it goes up a segment and it goes down a segment as well, which is creates a little bit of haziness to the symptoms if that nerve is picking up the tissue damage. So that's something to bear in mind. Yeah, Godsend, you've got a few questions to ask next time. Write them down beforehand. Guys, if you're ever going in to I know you're, I love it when people do this, right? I find it so helpful. Patience, that is. But if you're going into your specialist, write the list first. Like before you go in, go, boom, these are my questions. Bang, 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 bang. Get it out, have a look at it. Because they're there to help you. They are a expert to consult with. And it's good to gather your thoughts beforehand. And white coat syndrome is a real thing, right? White coat syndrome is where your brain just goes off as soon as you get in the room and you forget everything you wanted to ask them. And then you walk out the door and all of a sudden you got all the questions and your time's up, right? Write the questions down before you go in. Some of the inferior practitioners, medical professionals will not like that. And they can get over it, quite frankly, because they're there to help you. And if that helps you gather your thoughts, it helps them help you, even if they're a bit stroppy about the fact that you've got a sheet of questions. Annie has said, due to have a discectomy for my L5S1 herniation, consultant wants to hold due to improvement, but still in pain. That sounds like a good thing, Amy. That sounds like a good thing. If you start doing the rehab work and you start noticing improvement, they don't want to rush to do operations. You can always have the operation later. You can't unhave the operation. Everything is involves risk. I would suggest make sure you're doing the right sort of rehab work. It sounds like they've been a really responsible surgeon, right? Or consultant. You know, if you're making improvements, they want to be reluctant to do surgery. The last thing they want is you to be a patient that was on the up, right? But you're still having pains. You haven't healed, right? These things heal in months. One of the very important things for you to understand, Amy, which you might be at risk of falling on the wrong side of this, is when they do something like the discectomy, right? That is not the problem. They're going to cut that out. The problem is the fact that your annulus fibrosus, which is the ring that holds that bit in the middle in place, is broken. It's damaged. It's torn, which is why we have the disc bulge. They cannot repair that. They're not repairing that, right? They're cutting the bit of disc away. You still have an injury. So if the expectation is that we're going to, oh, they cut it out and I'll be good as gold, no. And if you're already making progress and these fibers are starting to heal up, starting to restore a bit of stability, but you're still in pain, like that's good news. It takes months for those things to heal. They are slow tissues to recover, right? And I think that's what they're doing a responsible thing. Hopefully they've given you some guidance on the rehab front. If you haven't got that guidance, check out the program. It'll help you. Just really continue to make the good progress that you've been making already. What else have we got here? Questions on TikTok. Can laminectomies to facet joint issues cause lasting problems? Whenever you're talking about taking something of the body out, I think, you know, we're changing the structure. I think, can you offset that by good rehab work, Louise? Yes, I think you can. But I wouldn't rush to those kind of procedures, to be completely honest. How long do the fibers take to heal? Tegan, you're talking about months. Months to respond to strain, respond to stimuli. So bear that in mind. And that is that you're going to need to, so for example, for your training, we go from healing into strengthening. Okay, they're going to patch up in a period of a couple of months, and then they'll patch up to a certain degree relatively quickly, right? Often when you stop doing the bad stuff, bending, twisting, all of that, and you start to learn how to control, many people with a long-standing back injury will notice that they start to feel better within a matter of days, if not weeks. That's not healed, right? Very important. But the scab has started to form. And I think it's just impractical to be able to say that happens in this time frame or that time frame or that time frame. And that's why your rehab is so important. Set the expectation that this thing is a month's process, not a days and weeks process. And that you'll often feel better before you are strengthened. And that is precisely why your rehab is so very, very important. Because your rehab is the only time where you're going to structurally and consciously challenge those tissues with a specific amount of load to see just how healed they are. So you have an intimate understanding that 5 kilos is okay, but 7 is not good enough, is too much for you. You have an intimate understanding of, in a couple of weeks or months' time, that 25 kilos is okay, but 30 is too much for that spine to bear. And so you understand how healed I am. Rather than saying when is it healed, implying there is a finishing to this process, there is not. There is a process by which you break the strength of your disc has built up so much that the activities of daily living are no longer a challenge for it. And that is hugely variable from one individual to the next. What do you do every day? If you want to, like me, do jiu-jitsu, then you're going to need to build up a significantly greater amount of strength in that disc again to be good, compared to, you know, John, who's retired and wants to potter around the garden, right? So you need to set appropriate targets, and just the blanket statement or question of how long till it heals, it's unfortunately one that doesn't get a clear answer, I'm afraid. Guys, what other questions have we got in here? I've got L45, S1 herniation, and guys, those of you on TikTok are probably experiencing a harder time here with the noise. It is crazy windy outside, and the shutters are just going absolutely nuts. So hopefully you guys can hear me over this. Sorry, I'll keep it going for a while. We've got 45 minutes down. We're going for another 15. Hopefully it's going to be helpful for you guys, whatever platform you're on. Is there any exercise to help me improve my leg numbness? Yes, Godsend, go and check out the program. I'll put a link in the chat. That's everything we talk about. We talk about the core 5, we talk about the dead bug, marching bridge, squat, hip hinge, step up. Learning those exercises correctly, you'll also see in the program the single leg hip hinge. That is what you need to do to get better, and pair that with some relief work. The program explains everything, so I would check that out, especially considering the status quo for you specifically. You don't need to be piecing things together online. You need to actually have a program and structure that can take you through it. What other questions have we got? They already did Jay, I'm not really going to focus on the mid-back stuff. Like it's a bit off topic here, I'm afraid, and really trying to focus on the lower back. I'm sorry. I've got so many questions on here on lower back stuff that I need to stay focused. Guys, these live sessions, like, they're focused around helping you guys with lower back issues. I appreciate there are other areas that are problematic, and when we have members in the program and they've got neck issues and other things, like, we help them there. But for these, I want to be laser focused on the lower back. So sorry to those of you where I'm not addressing things that might be the thoracic spine, etc., unless it's directly relevant to the lumbar spine. Program starts with phase 1 and then you move to phase 2. That is correct. I haven't seen the context of that comment. Oh, silence. Isn't that nice? They already did a laminectomy during my microdiscectomy, so I have 45% of facet on one side. Yet, Louise, everything we talk about spine stability, you need to learn harder. You need to learn better. You need to be better at it, because you need to offset the changing architecture. So where people have what's called congenital abnormalities, that means you are born with some sort of change in structure. We think about Bertolotti syndrome, we think about sacralization, lumbaralization, people with extra lumbar spine vertebra, people with one fewer, people with missing 11th and 12th ribs, in the lumbar spine. All of these other variations. To the degree you've got that, or a post-surgical variation, a fusion, in Louise's case, you need to be and have a better control over your midsection. You need to be steadily building load tolerance to a point slowly over the period of months and years ahead, Louise, that is greater than the average around you, your contemporaries, age, gender, all that kind of stuff, right? And then once you've done that, you've got good axial load tolerance, which you can build up slowly, giving the tissues time to recover, understanding that the muscles change in weeks, and the spine and the ligaments and the tendons change in months. That's very important, because the two can race ahead of one another. You then look to the hip mobility to see, do we have greater than average hip mobility? You want to build slightly greater than average hip mobility, because that means that your lower back is less likely to be deployed in vulnerable positions and have to be involved. Are you going to be able to bend your back? Of course you are. But you've got one less functional joint compared to everybody else. And so your hips play a greater offsetting role for the long-term health and well-being. You do that, you're going to be fine. You're going to be just fine. But it's going to take you some time. And as long as you're prepared for that, there's no problem. And that's basically everything we teach in the program. It's just more important for you than the average. And it's important for the average anyway. Like, if everybody did what we do in the program before they injured their back, happy days. Can't stop you injuring your back, but you'll recover real quick. Storyteller said, we've got Christian first. I flared up in June, but now in the day I can move around pretty much pain-free, get pain at night, awful. Yeah, so this is a really classic recovery for lower back pain, in that things settle down to a point they patch up, right, with reference to the earlier question. The disc herniation settles, it's got some scar tissue, that scab has formed, to the point where it's not significant enough to take you out and be in a lot of pain from one movement to the next, and you've adjusted and modified your daily life, Christian, and others, because this is so common, that you're getting little aggravations, but because you're mobile still through the day, little movements going through the spine, you prevent the inflammation from building up to any significant level that you notice. And it's only when you lie down in bed at night and maybe wake up in the morning or partway through the night that you notice the inflammation is building and your back's sore. And this is often where people get to the point where they stop progressing on with their rehab because they kind of feel okay during the day. And the practices that got them to that point have stopped. And they're no longer building resilience into the back. And that's something we've really got to watch out for. you have to continue to build strength and resilience. And what will happen is as you build strength and resilience, your back will be more capable of dealing with the stress and strain of daily life, so that it's not actually being aggravated now through the day, so the inflammation isn't building up at night, so you don't have pain at night. So you're partway through the process, Christian. Very, very common, but make sure you're digging back into the rehab work and making sure you're building objective strength into the lower back. And you're still being careful with what you're doing. You might be getting away with some stuff now that you weren't getting away with earlier, and you think you're getting away with it, but you're actually not. So bending, twisting the spine, all that kind of stuff, violating principles of a neutral spine a bit more brazenly than maybe you were a couple months ago. Storyteller said, if sciatica and back pain is very severe and inflamed, then when should we start the hip hinge? Storyteller, you're already doing a hip hinge. You're doing it when you get out of bed. You're doing it when you get off the toilet seat. You're doing it when you get dressed to put your underwear on in the morning, right? You're doing it every day. So you can either, no matter how bad it is, you can either learn to do it correctly, focusing, or you can continue to do it blindly every day. And this is, I did a TikTok comment on this earlier today. Like, people think, oh, I'm too severe to do any exercises. It's like, are you floating? Like, are you just lying in bed all day? That's a problem in of itself, right? But people, I'm too severe to do it, but you're still going to work. Like, I'm too severe, but I still walk the dog. I'm too severe, but I still went downstairs in the morning. I'm too severe, my back pain's too severe to do exercises, but I still went to the toilet, right? I use those as examples because everybody's doing them, right? So carefully learn the hip hinge, right? The hip hinge is not with a 60 kilo weight. The hip hinge can start off with a chair in front of you, stood here and go, that could be a hip hinge, right? Recording yourself 16 times, watching the video back, watching someone else do it, watching it and then trying it again, okay? There, right? You find what you can do. You find what you can do and then you build from there. If you can't do it, make it easier. Can't do it, make it easier. Can't do it, make it easier. To the point where I just showed you. That might be demoralizing. I had someone say, yeah, well, that's really demoralizing. It's like, but that's the truth. If you suck at something, you need to first acknowledge that you suck at it to then ever go about making it better. And actually, sometimes being so severe is actually an asset because it forces you to get things right. When you're not as severe, you just kid yourself into thinking you're actually okay at the exercise or the practice or the movement, and you're just getting away with it. Like Christian's getting away with doing a bunch of stuff during the day because things are at such a point in the healing process that he can get away with it. But we're getting away with it. We're not actually really doing things well. What else have we got here? Questions wise. Can I do every movement in your rehab program with the facet reduction? I'm pregnant too. So yes, because when you're doing all of the exercises of the program, you're not moving. Now with the pregnancy situation, that is going to be difficult. I don't know what trimester you're in. As you start to get to around, I think it's the 16-week mark, you start to like lying on your back, lying on your tummy, those things are going to be kind of off the cards for a variety of reasons. And obviously you check that with your midwife. But learning the movement like the squat, the hip hinge, and the step up, specifically the load-bearing movements, doing a bit of the hamstring stretching, the lower body stretching, those things are all going to be perfectly reasonable to do through the entirety of the program. You obviously need to adjust the intensity of those as you get closer and closer to the date. But learning those now, before the new ones here, the little ones here, and all that kind of stuff, it sounds like, what else are we going to do? What else are we going to do but learn how to control ourselves better? And the whole point of the program is it's learning stability. There are going to be, unfortunately, during the pregnancy process, every lady's different, and every pregnancy for every lady is different, right? Lara had a different time the second time versus the first, and I'm sure the next ones will be different as well, right? But make sure that you're not under the false pretenses that sometimes you're not going to be the one making mistakes with pregnancy specifically, right? It's just your body's changing, right? You've stretched out a little bit more. There's a little bit more relaxing in your system. So your ligaments are getting a little bit looser. And now you've got a bit of instability there on top of what you've already got, right? And then you're going to be in pain for a bit. And unfortunately, as we go through, especially the latter stages of pregnancy, it's more about symptom management because there are factors there that actually we can't really do too much about, right? We're pregnant. Enjoy it as best you can. Be as careful as you can around with the lower back specifically, and learn what you can technically. And as you get closer to the back end of pregnancy, you're not doing things as strenuously. So it might, but at the end of the day, doing a squat like this, okay, with your bump, you've got your bump here, like doing just some careful squats, that's not strenuous. Now, for some ladies that are pregnant, before they were pregnant, they might be able to squat with 100 kilos for reps, right? Not loads, but some. And so for them, a 60 kilo squat is an easy squat. I always remember this lady that was in the gym that I was at many years ago, very pregnant. And she was still doing stuff, but she was really strong beforehand. So the intensity needs to be dialed around a little bit is what I'm saying there, Louise. and you will need to be aware of that. But that's where having support and help, through the process. We've had a good number of members actually, like, they always like, oh, don't tell. He's like, I just want to be anonymous in a number of cases for a number of different reasons, right? They're pregnant. I can think of one or two right now, that are in the back end of the pregnancy, I believe. Yeah. So much further on than you, Louise, that are in the program, and like, it's just there to help you guys, right? The advice changes obviously for those ladies that are pregnant, because there's certain things we just can't do, but that doesn't mean you don't do the exercises, right? The squat, the hip hinge, they're still worthy of practicing those, even if you're just practicing refining your technique for the latter stages of the pregnancy. Something to think about. I hope it's helpful, especially for those of you ladies. I know it's something that, especially if you've got back pain, like we get questions like, oh, can I be pregnant if I've got a bad back? There are some ladies that the process of pregnancy, it temporarily cures an autoimmune condition because of what's happening. Others, they have terrible flare-ups of other sort of things, because it's so different with each individual process, and it's not my area of expertise, so please bear that in mind. I'm looking at it from the back point of view. But there's so many variables in the pregnancy process that are going to give extra kind of points of information, I suppose. We can just focus on the structure as best we can. And, like Louis said, it's hard to know what's pregnancy and what's due to the back problem. But at least if you've banked good technique and good form on those exercises and understanding, you have an appreciation for how strong you are. I think that can be very valuable as you're going through the pregnancy process, period. Trouble with L4, 5S1, what can I do? There's three things you need to do. And this is basically everybody in the chat and everybody on YouTube that's watching this is basically in the same boat. You guys all have L4, L5S1 issues of varying degrees. You need to have some element of relief-based work. Relief-based work is stuff like the towel decompression. Relief-based work is stuff like the bed decompression. It's lower body stretching with a neutral spine. It's those kind of things, right? Contrast bathing, walking, all of those things are relief-based strategies that you do in conjunction with, at the same time as, spine stability work. We break it down into 4 phases in the program. Exercises like the dead bug, marching bridge, squat, hip hinge, and step up. All of these exercises, you hold a neutral spine and you do not deviate from the neutral. The rehab is what gets you better. Relief-based work is not cumulative. So you always start the rehab immediately and the relief work runs on side. Always. If you do those spine stability exercises incorrectly, you will experience pain. So don't do them incorrectly, do them correctly, but that sometimes puts people off. Understand that you're probably not very good at them to start with and that you need to learn, and that there are resources there and the support there within the program, for example, to help you do that. But those exercises are fundamental, foundational. They're excellent at being appropriate for everybody, scalable and adjustable in their difficulty or their version for everybody, and that once you've learned them, you just keep doing them over and over again. You refine them and refine them and refine them over the long term. And as you build strength through those exercises, you get your back better again in an objective manner. So that, for example, you started out and you weren't able to move. And then you could use a 5 kilo and you could do a goblet squat, right? And then over the course of the months, you got the 80-pound kettlebell and you were doing a low kettlebell squat, right? Very clearly, I have improved the strength, the resilience, the load tolerance of my injured L4-5 and L5S1 discs and spine in general, because I could only do 5 kilos 6 months ago. And now I'm doing 36 kilos, 80 pounds, as an example. And that's the best measure of how healed is my disc. That's the only answer. That's the only answer we can possibly give. And that's the only way we can really get any material information that is something as a kind of like a yardstick. Sorry, TikTok just wants to check I'm a human. And I do these long live streams, it always needs to check. I'm gonna go through a few more questions, guys. We just crossed the 1 hour mark on TikTok, 58 minutes on YouTube. So guys, if you've got any more questions, post them down now sooner rather than later. I'll go through a couple more. Guys, those of you on TikTok, if you need more help, go up to the profile page up here. There's a link in the profile page. That's to the program. There's also a video on the pinned video on our profile that explains more about the program. Those of you on YouTube, I've posted it in the chat. Oscar said, can I do seated leg curls? You can, but Oscar, just be mindful. Seated leg curls isolating the hamstrings. And so if you hammer them really hard and you've got some tight, stiff hamstrings afterwards, just make sure you manage that stiffness in the hamstrings, because that will restrict your hip mobility, which could irritate the lower back after a couple of days. So perfectly fine with the phase that you're in. But I would still be focusing a little bit more on the load building, Oscar. I think you're around about 30 kilos if memory serves on the squat or hip hinge, maybe a little bit more than that. I'd probably focus a little bit more on building You know, if you've got extra time, you want to do some isolation work for the hamstrings, go ahead. That's okay. You've been making good progress anyway, so that's fine. Just be wary of that delayed onset muscle soreness or post-workout muscle tightness if you're hammering the hamstrings on the hamstring curl. Nat has said, I had an L5 disc, a herniated disc for 18 months and just had a discectomy. I'm assuming the L4 disc is probably gone. Very, very common. Make sure you're doing the rehab work now. You've got to do the rehab work. That's what gets you better. Spice Latte said, I have a disc bulge, mild facet arthropathy. Is this curable? I don't know what you mean by curable, but can you recover from that and get back to doing normal things and rebuild strength, health, and resilience? Yes, that's what we've been doing for years. In the program or clinically, it's an injury that you can recover from. You just have to do the rehab work, right? It's not overnight, but you need to do the work. And that's everything we've been talking about. Spice Latte, I'm pretty sure you've been on some of our other lives. Check out the program. That'll help you do that. Should the back be flat or lordosis be present in the hip hinge? So, very important question. Because sometimes people get taught to do things like the pelvic tilt, and that is wrong. A human being, which all of you guys are, as far as I'm aware, has a natural lordosis. I always find it hilarious because it shows ignorance when someone says, my doctor said I have lordosis. It's like, that's like saying you have two arms. Like, so what? Like, doesn't mean anything, right? What they might mean is you have hyperlordosis, and they probably haven't measured it, so they're probably speaking incorrectly. But there's a lot of stuff on the internet about flattening the back to the ground, doing a pelvic tilt. You do not do that. Your spine, now observing from the surface, it might look like a flat back, right? Because you've got muscle here, and depending on the development of the glutes and development of the back muscles, it might look like you have more or less of a curve, or it might be flatter. But there is a difference, right? So if you look at me, and my glutes stick out a little bit, so, you know, take it with a pinch of salt. As I stand up in a neutral position, you can see clearly that my lumbar spine starts here, where my hand is. So I'll put my fingers there, there. That's the start of my lumbar spine is about here, okay? So as I'm going through the hip hinge, I'm maintaining that curve, but my shirt's pulling out over the top of it as I come in here. You can still see, though, I am not rounding my lumbar spine. It is a hip hinging motion. But if I move my back out the way, if I pull this forward like so, you can see that the curve, there's still that element of curve there. My back is not, as opposed to this, okay? That is very different, right? That is wrong. But the most important thing you can do to help you get this is go and stand against the wall with your bum, your middle back, and your head against the wall, and then walk away from the wall. That's probably neutral for more or less everybody, right? Unless you have evidence to suggest to the contrary, which would be a standing load-bearing x-ray that's measured your spinal curve, and then you just hip hinge back, and boom. Don't move anything. Don't do any funny pelvic tucks, any funny pelvic tilts. You don't need to do that. That's incorrect. And that's what we should do. Sometimes people get instructed to do a pelvic tilt. Do not do pelvic tilts. That is incorrect. So hopefully that makes a bit of sense. The lordosis should be present. We shouldn't be consciously eliminating it. But as it looks from the side will depend on where exactly your glutes stick out more. It's going to depend on a number of different factors as to how it looks. I would strongly recommend if you're taking, Louise, this is going to be tough for you because of the pregnancy, right? But if you're going to do this at home, take a video with like just a bralette on or something like that so you can see the skin and the tape test. If you go on to, in fact, Louise, just send us a DM after this. Say, hey, Mike, can you send me a link to the tape test? There's a video on the website. It'll show you how to do the tape test. Do that. That'll help whilst you're doing a hip hinge, and you'll be able to see if you're doing it right or not. What have we got on here? We've got Oscar has said, dead bug is not, also the dead bug is not good for me. Any exercises than the dead bug. Not sure what you're saying there, Oscar. Let me know in the members group. Just post a little bit about the dead bug and what you're struggling with about it in more detail, because we're going to finish up this live in a second. So make a post in the Facebook group, and I'll go through that with you there. We need to figure out how we can do the dead bug. Where are we failing? Because we'll be missing something, certainly, when we say the dead bug is not good for me. Christian said, just to reaffirm, you can recover from herniated discs to an elite level. I watched it. Oh, Christian's kind of confirming what I said. Yeah, man. Like there was, so I know of two cases that might fill you guys with a little bit of confidence. First one, I've mentioned this before. someone I used to train with, or trained at the club I was at, who got a herniated disc, had a microdiscectomy, and within 9 months was back competing at jiu-jitsu, which is quite a back strenuous activity. And the other individual is a bodybuilder who I happen to know has a spondylolisthesis, who is competing at as a pro level on the pro stage, right? As a bodybuilder with a spondylolisthesis. That's where one vertebra is sliding forwards, right? You can do an awful lot. You can do an awful lot if you have the appropriate rehabilitation work, if you rebuild strength and stability, if you have that to start with before you injure yourself, you know, you can do very, very well. I watched a GB hurdler this morning, Christian is saying, and he had a herniated disc apparently, you know. You can do an awful lot if you're in good physical condition. The problem is a lot of people are not in good physical condition. And I think even more so is true. A lot of people can't really identify what good physical condition even means. Strength. They're like, oh, I'm fit, I'm healthy, I do stuff. It's like, okay, but why do you say you're fit and healthy? Based on what? Objectively, what does that specifically mean? Oh, I walk the dog. It's like, no, that's not fit and healthy. You just walk the dog, right? Like objectively, what do you low tolerate? What can you low tolerate? Hip hinges, squats. Can you move through those correctly? What do you run? How fit are you? Cardiovascular, like how fast can you go? How conditioned are we specifically? Oh, I run 400 meters in this time or something like that. Or I run a 5K in 20 minutes, whatever it may be, right? Have numbers, have objective markers. This belief that, oh, I'm fit enough for what? You know, you need to be fit enough and strong enough to be able to lose a lot and not be in a state of disability. That's something we should all bear in mind, especially for long-term aging. And Dr. Peter Attia talks a lot about that in his book Outlive, which is a good read. I would recommend it. Guys, I'm going to wrap it up. Hopefully this has been helpful for you guys. Sorry, I'm running it to the end. We've got a lot to do this afternoon, and I just wanted to jump on here and make sure that I got a chance to go through with you guys. If it is helpful, guys, please do consider sharing it. I appreciate you guys turning up. If you need more help with your back pain, your back recovery, the rehabilitation work, support along the process, whether on YouTube, watching this, whether you're on TikTok, just check out the various links that are posted all over the place on the profile page, in the chat. Guys, I'll see you later this week. Thanks for joining. And YouTube. See you next time. Bye, guys.